Brother Sterling, I think you're muted.
Good evening, everyone. I'm Dr. Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated, and I would like to welcome you to the Alpha Phi Alpha Surgeon General Initiative Weekly Health Webinar. On behalf of our General President, Brother Dr. Willis Lonzo III, I thank you for joining us for this week's conversation on mental health. Leading the conversation is our Deputy Surgeon General for Mental Health, Dr. Ron Kennedy Bailey. Dr. Bailey serves as chairman at LSU Health Sciences Center, Department of Psychiatry, and is the Assistant Dean for Community Engagement. Dr. Bailey received his medical degree from the University of Texas, Medical Branch at Galveston, and he also completed his residency training in psychiatry at the UT branch at Houston. While in residency, he was the chief resident and completed a fellowship in forensic psychiatry at Yale. Dr. Bailey has held leadership roles in academic, organizational, and professional settings. While at the University of Texas at Houston, he received the Outstanding Faculty of the Year Award, and due to his volunteer work, particularly during Hurricane Katrina, he was named the National Medical Association's Physician of the Year. He subsequently became the National Medical Association's 113th president, serving from 2012 to 2013. Most recently, Dr. Kennedy Bailey is the Chief Medical Officer of the Kindred Community Health System and remains there currently. I'm proud to have him join us as Alpha Phi Alpha Deputy Surgeon General for Mental Health. Good evening, Dr. Bailey. Have a great show.
Yes, thank you very much, Brother Sterling. Ron Bailey here. I'm very proud and happy to be in this role of Deputy Surgeon General for our, I think, really outstanding initiative on the Surgeon General Initiative addressing the health, I think, of African American men within our fraternity, and hopefully over time, even outside and going forward. I think that the effort led by our General President Lonzo is an outstanding one, because many of the challenges that African American men have in their health currently, that we've had historically, and that I think increasingly in current times with the pandemic and the like, that we have in many regards going forward. We have two outstanding brothers on for tonight to discuss issues regarding mental health, I think, in our community. Our brother Melvin Hinton and brother Darren Wright. Their CVs are attached, so you can sort of review them. But I just want to say a few things about them personally as we get started. Brother Hinton first is the Director of Correctional Healthcare for the Illinois State Department of Corrections. And it really speaks, I think, to the urgency and importance of African American men being in these level roles going forward. So many persons in general, many African American men are involved in the correctional system and still require high quality evidence-based care for their health. I think that we probably have, as a community, perhaps missed this construct historically as we moved away from the term community psychiatry and community health a few decades ago. But so much of, I think, community health happens in these settings. The reality is very often individuals will come out of a DOC type setting, for example, Department of Corrections, and either have illness that has been poorly treated, undertreated previously, that we hope we were receiving good quality care while they were inside the DOC, and we hope that can actually be continued. So we need to have a bi-directional communication between providers outside that system and those that are inside that system. I myself have been in the Department of Mental Health for much of my career, and our ability to work in conjunction with Departments of Correctional of Care, I think, is actually improving the quality of lives of individuals going forward. So I want him to kind of speak about that in some regards tonight, and many of the challenges that he has being over in an administrative role over such a large set of individuals in a Department of Correction setting. Brother Wright, I'll go make some comments, and I will, again, before he comes forward, runs, I think, a practice involved in clinical psychology for a group of individuals, I think, in a similar type setting, persons who've had long-term chronic mental illness, and individuals who've had issues regarding health care that often is challenged, I think, in our community. So what I actually hope both of these individuals will speak about tonight are concerns, first and foremost, about African American men and our health and our particular challenges. Secondly, what particular difficulties they may have experienced in the systems that very often provide some unfortunate barriers and hiccups along the way and hurdles for men receiving health care. And third, what some of the particular pearls that they can offer, I think, for our audience going forward to treat these particular patient groups in an evidence-based fashion that's likely to better over our outcomes. We'll start with Dr. Hinton, and he'll be followed by Dr. Wright. Thank you, brothers, very much for joining tonight. Dr. Hinton.
Good morning or evening at this point. Thank you again, Brother Bailey, Brother Dr. Bailey, Brother Surgeon General Sterling, and of course to our General President, Brother Lanzer, for this opportunity to come to you all and really talk about this important topic on mental health awareness. I'm going to share a screen. Thank you. And bring up our presentation for everyone. And Dr. Wright is also going to chime in a second as we talk about this. Our goal today, and we're going to get to the purpose of our workshop in a hot second, but our goal is really to bring forth awareness, right? To tease out some myths, talk about some facts, and really try and break down some stigmas in the African-American community particularly, but minorities in general as it relates to mental health and mental illnesses. I'm going to advance. And Dr. Wright, you want to jump in here as well as we talk about the purpose of our workshop, demystifying mental health and mental health conditions, embracing mental health as part of our overall health and well-being. We're going to discuss some common examples of mental health conditions. We're not going to get too specific. I don't want anyone to think that we're going to start defining schizophrenia, major depression, anxiety disorders. We're going to talk very globally because we firmly believe this is step one in a series of steps that's going to talk about mental health and increase our awareness overall. Some common barriers to treatment for African Americans, and again, African Americans really, and minorities in particular. And we're going to provide some mental health resources for African American men in particular, but they're not exclusive to men, so that it'll be certainly representative and able to help others there. Dr. Wright, you want to jump in here before we move on?
Greetings again to our brothers and our listening audience. It's an honor and a privilege to be a part of the Surgeon General's initiative. At this point in time, I think, Brother Dr. Hinton, if we can move forward with the workshop, as you know, we will work collaboratively in an interprofessional manner to address and provide really a global overview of mental health and mental health awareness. So please proceed, my brother.
Absolutely. And we will remind everyone that if you have questions or comments, please utilize your chat feature. And at the end, we will have an opportunity to address them. Where to start this conversation, this global conversation, is really to kind of define what mental health is and certainly what mental illness are. But mental health includes our emotional, our psychological, and social well-being. It affects how we think, how we feel, and how we act. So every aspect of us as a being, as a human being, has an impact on our mental health, and our mental health has an impact on every aspect. Think about it this way. If your thoughts are good, your cognitions are good, your mental health is positive, it's upbeat, it's healthy, you're more motivated to get out, to pursue goals, to be social, to interact with others, to deal with challenges that come up in life, right? You can kind of figure out, okay, well, that was hard, but this is how I'm going to deal with it. This is how I'm going to cope with it. This is how I'm going to get through this difficult spot and move on. Conversely, if your mental health is poor, okay, you're not feeling well, then you're less motivated to get up, be social, right? You're less capable and equipped to deal with challenges that you may face, right? So you've got some issue at work or some issue at school. Your mental health is not in the best shape. you struggle with dealing with that issue in the workplace or in school, right? So that's why it's so important that we take care of our mental health, that we have a full understanding of our own well-being, okay? Mental illnesses are health conditions. And as you see on your screen here, we're going to underscore health conditions. And I'm going to get back to that in a hot second. So mental illnesses are health conditions involving changes in emotion, thinking, or behavior, or some combination of those. Mental illnesses are associated with distress and or problems functioning in social, work, and that includes school or university settings, or family activities, okay? So if there's some kind of distress that's going on, you have then a diminished capacity to function within those environments, then you know something is going on with your cognitions, your thoughts. We know something is going on with your mental health, and it could in fact be a mental illness. I want to stress here that mental illnesses are health conditions. No different than we talk about preventions and interventions for stroke or hypertension, coronary artery disease, lung cancer, or dental, oral hygiene, oral health. Mental illness is a health condition. I think if we start to really embrace that and accept that, then we really do combat some stigma that comes with mental illnesses and seeking treatment and interventions for that. It's a health condition. If you take care of it, then your entire being, your entire self is improved. If you don't take care of it, then your entire being, your entire self is impacted adversely. And certainly, as the last point shows, all of us have experiences from birth all the way through death of going through developmental stages, right? Mental health is that important. It teaches us how to deal with adversities. It teaches us how to go from one stage to another, how to cope more effectively in our environment.
Thank you, Brother Hinton. And I think this leads us into our next slide, as we can see. And I think that Brother Hinton really provided us, in my opinion, with a clear understanding that, as we can see, that our health, it is a state of our complete physical, mental, social well-being, and not merely the absence of disease or infirmity. Why do I underscore this? It is interesting that this statement, as you can see, is the preamble to the Constitution of the World Health Organization. And this declaration was made in 1946. So clearly, as a global community, a global world, we recognize this. However, while it has been recognized in terms of the letter, we have not in spirit, as a global community, really addressed this issue. I would add furthermore that from an Afrocentric perspective, because I teach at the Whitney M. Young Junior School of Social Work, and one of our tenets is understanding the Afrocentric perspective, that an important part of this is our spiritual dimension. So we will also include one spirituality, not in terms of our religious affiliations, but just understanding from that global perspective. Just like a spider web, if one aspect of that spider web is impacted, it reverberates throughout the web. Therefore, in some way, manner, form, or fashion, our mental health is intrinsically related and interrelated, as Brother Hinton shared before, to our overall health and well-being. And when we begin to embrace this, we begin to see ourselves not in this bifurcated manner, but understanding ourselves from a very holistic being. Next slide.
What you all are going to see here are some statistics, and I'm not going to go through each point on the slide. I'm going to emphasize a couple of things. we want to make sure that people understand that mental illness is common. It's common in our culture. It's common in our country. It's common throughout the world. I'm emphasizing this because I want to, again, break down those stigmas, right? Somehow that if I have a mental illness or I'm in therapy or, I'm seeing a counselor, that somehow makes me weak or inferior. That's just not true. Let me point to two particular points here. The prevalence of any mental illness, statistically, when we look at young adults, ages 18 through 25, that accounts for almost 26% of our population. Adults 26 through 49 experience some form of mental illness at about 22%, and those over 50 at about 14%. So think about that, right? It's commonplace for us to know someone or experience some form of mental illness. Nearly 1 in 5, 19% of US adults experience some form of mental illness. That's 46.6 million individuals. And that I will kind of share with you is probably low because that's from statistics from 2017. Okay. So, and we haven't even started talking about serious mental illness when we get into schizophrenia or psychosis or serious mood disorders. We're talking about any mental illness. And so I again want to stress, this is something that is common amongst people within our society and certainly within our culture. I don't want anyone in this area, in this arena, to think that we are going to define every mental illness or psychological diagnosis. We're not. That's not our point. I also want everyone to understand that mental illness is always viewed on a continuum, right? You can have people on either end of the spectrum, right? From having mild symptoms to severe symptoms. So how you experience depression or anxiety or have some type of adjustment will depend uniquely on the individual and that situation and the contributing factors, right? Most people will experience depression at some point in some form in their life, and they'll probably end up somewhere in this area, right? Others might end up more in the severe area where they might have to have some psychiatric interventions or other interventions, but it will vacillate. It will go up and down, right? The more interventions you get, the more services you get, we hope, knock on wood, the less severe will be your symptoms.
So Brother Hinton and listening brothers and members of the listening audience, as we can see, we've already laid out, number one, that mental health is common. It is a part of our overall health and well-being. Number two, that a significant amount of individuals within our society here in the United States and globally may experience some form of a mental health condition. And we've already laid it out that it's a part of our overall health and well-being. Part of this also is understanding those factors that influence our mental health. So some of these factors from a public health standpoint, as some of you have read my background in terms of my training in public health, the issues around social determinants of health. And what are those? As we can see, those are factors that impact our overall health and well-being. As such, as we can see, that we are very much a part of our communities, our bioecological system, and it impacts us and we impact it. So therefore, these different dimensions as we see in terms of economics, food, education, healthcare, our social interactions, and environmental interactions play a huge part in our overall health and well-being. I'd like to give you a further example on this. For instance, as it relates to our environment, when we look at our environment from a micro level in terms of our homes, our experiences in our homes and how we interact with each other, and then from a meso level in terms of our interactions with our community, our neighbors, the institutions that impact our lives, and from a macro level in terms of our interactions with our greater society. And as we know, the issues around structural racism and implicit bias can have an impact on our health and well-being. So it is important for us to understand, regardless of our socioeconomic status, that at some point in time, there are many factors that influence our health and well-being. And part of that is our social determinants of health. Next slide, Brother Bill. Equally important, as we have just laid out, is our understanding that another aspect of these factors are our biopsychosocial factors. And I would like to say, brothers, as we know, and to our listening audience, biopsychosocial factors simply are social factors that are characteristics that influence our individual in terms of psychologically and socially. And as we can see, there are different areas in that, in terms of our social interactions, in terms of our family dynamics, how we interact with our family, our relationship, our temperament, our social supports, how that also impact our understanding and our concerns around mental health. In terms of psychological factors, and some of those factors, as we've mentioned before, in terms of our beliefs, our attitudes, our behaviors, which are a part of our individualized and our collective worldview in terms of our experiences, and our coping skills and current and past traumas also impact our overall health and well-being and mental health. And I think, as Brother Hinton had pointed out before, on that continuum, as we can see from where there is no symptoms to moderate to severe, a lot of that is influenced by these psychosocial factors and social determinants that we experience in our lives day to day. It doesn't matter in terms of our socioeconomic status, we are all susceptible to as part of these issues and concerns. And that's why it is important for us to remove the stigma associated with mental health and begin to understand the bigger global picture with that. Also, in terms of our biology, in terms of nutrition, what we eat, what we don't eat, in terms of other things that may be going on with us, it also has an impact on our overall health and mental health. So again, brothers and our listening audience, it is important for us to have that global understanding as we look at it from a micro level to a macro level and understand again how much this is intricately integrated in terms of our overall health and well-being.
And certainly, as your slide points out, we all, have seen that impact of being sequestered in our homes,
Exactly.
limited movement for quite some time, right? We're all going on a year and a half, and hopefully everyone's starting to see all those symptoms, right? All that impact of being confined to a space, having some stress, right? Stress associated with how am I going to get the kids, the education that they need, how I'm going to, balance my work and home life when I'm doing everything from Zoom or sitting in your home office or even having to go to work in a time where there can be extreme risk. So yeah, absolutely.
And before we discuss this, I think the other issue is just around the whole concerns around upskilling and reskilling. As individuals think about, in terms of upskilling, they're required to learn new skill sets and the anxiety that can come in around that, and the reskilling as COVID-19 continue to redefine what work would look like. All these are other factors, societal factors that impact us. Another important area as we talk about the common barriers to treatment as it relates to mental health, and this is really an important point here for our listening audience and for our brothers, is this whole notion of access to care. And as we can see, only 1 in 3 Black Americans who need mental health care receive it, right? And that's coming from NAMI. But I think it's important for us to have a further discussion in terms of what is access, because access goes beyond just having an insurance card. You know, if we look at the definition provided by the Institute of Medicine, it provides us with a very clear definition. I'd like to read very quickly. It says that it refers to the timely use of personal health services to achieve the best possible outcomes. And we recognize that there are many dimensions to that, Dr. Hinton, because having a card does not mean you have access. One still has to consider the person's socioeconomic status, their geographical location, how close they are to services. And even if they are close to services, do they have the means to get there? Thirdly, even if they get there or they can get there, how are they received? How are they received in terms of those healthcare providers, how welcoming they are to them? Do they make them feel welcome? And we recognize that when the area of mental health, because of this stigma, there sometimes is a different way people are received than if you were showing up at the hospital to just take care of, quote unquote, a health issue, because we have bifurcated health from mental health.
There's so much to unpack there, but I couldn't agree more. If you are fortunate enough to have healthcare in this country, that's one step, right? If you are fortunate enough then to have literal access to care, right? I got a car, I can drive myself to appointment or whatever. That's one thing. I think the other thing, Brother Wright, is do people have an understanding of their healthcare? For even those who have it, right? Anyone who's had to deal with their insurance provider, insurance company, managed care, you've got to know, I've got to go to this person to make sure I have that authorization. I've got to go to this website to see who's in my network, so on and so forth. Because if you don't, there can be some financial consequences to that. And so I would certainly encourage, and I tell this to my patients all the time, I encourage them to educate themselves about how the system works, where they can get access, how they can get access. Certainly, one of the benefits of our world, our COVID world, has been increased use of telehealth services, particularly telemental health and telepsychiatric services. For some people, that's a very viable option. For others, it may not be, but you still got to know how to navigate in order to access care.
You are so correct.
Stigma. And you touched on this, right? Because there's stigma about, do I access care? What happens? Am I going to get a label? Am I going to be over pathologized by providers? There's a lot out there that we all have to be aware of. But we can't stifle ourselves because of stigma. Mental health, mental illness is a health condition. If we don't take care of it, then we will be, by definition, unhealthy. So we've got to conquer that fear, conquer that stigma. I think it's important for us to define stigma. And I'm just going to take a hot second to talk about two ways that you can look at stigma. Stigma from a public stigma perspective and a self-stigma perspective. And I would argue, and the points up on this slide support this, that as African Americans and minorities in particular, we really have to grapple with both. Public stigma is the belief that a person who seeks mental health services is perceived by the general public, right? Exterior, the general public, as flawed and socially undesirable. So somehow, because I am seeking mental health services, the world's going to view me as undesirable, as weak, as whatever the case is, right? Self-stigma is when an individual's negative perception, right, their negative thoughts about themselves are negative for seeking help, right? So if I go and see a therapist, if I go and see a psychiatrist, if I'm taking psychotropic medication, my antidepressants, what have you, then I'm going to also view myself as weak, as deficient, as, problematic. We need to combat that, because that is just a myth. I refer you guys again to our earlier slide. One in four people in this country have experienced some mental illness, right? Yeah. It's that common. So we've got to buck that stigma. There's nothing weak. There's nothing deficient about taking care of your mental health and about seeking mental health services. There's nothing weak. There's nothing problematic or dangerous by taking psychotropic medications and staying compliant with your treatment plan. Nothing weak at all about that.
Brother Hinton, I'd just like to add one dimension to that, another point, because I think it's important that as we think about also, we look at these linear and circular logic of thinking in terms of, we recognize that the way how we seek services and the impact in terms of stigma also has to do with our historical experience within the United States. And this whole psychology of cruelty. We have been pathologized, and therefore all men see themselves as, we have to be strong. But within the context of the African-American experience, we have had to carry this other burden of being extra resilient. Somehow we are the poster board for resilience. And therefore it acts as what you just talked about in terms of self-stigmatization. And that is a part, I think, in terms of helping through these discussions and this dialogue to normalize this and say, we have to move beyond that. We are not the poster board for resilience. And that, yes, we are resilient people, but we're human. We have to humanize this condition and move it as an overall part of our overall health and well-being.
Without question. We want to make you all aware of mental health, aware of mental illness. Educate yourself about those processes and this subject. Because once you do, then you're able to combat when folks, particularly providers, are inappropriate, are over pathologizing you, are marginalizing or minimizing your concerns. You're able to say, wait a minute, doc, counselor, social worker, whomever. You're able to say, no, something else is going on. This is important. This is a part of my overall health, and I need to make sure that I am, in fact, healthy. Right? We need to make sure that we are educated enough to lobby, to advocate for ourselves, right? What you see here on the screen talks about provider bias and inequity of care. We know that. And we can have a whole conversation on why that is and how, we're going to combat that. But at the end of the day, we have to be serious about our health condition as it relates to our mental health.
I agree with you 100%.
So here, Brother Wright, we've got a couple of resources on the screen. I just want to leave this up for a second. You want to talk about a couple of these?
Yes. Again, to Brother Hinton, to our brothers and listening audience. Again, we wanted to approach this from a strength-based perspective. So we provided a global overview, but not just to provide you with information, because we always say information is good, it's powerful, but it's only information if you don't put it to use. And we wanted to provide you with useful tools, resources that we felt that we, in our opinion, based on our research, will be helpful for our brothers, their family members, and to our greater listening audience. As you can see, these are some resources with providers who will be able to provide you with culturally responsive care. And we're not saying that the provider must be of African descent to do that. But what we're saying is that whether that person is Black or not Black, that person will value you, not stigmatize you, not pathologize you, not engage in any type of implicit bias, but be able to approach you from a standpoint of understanding your humanity. And therefore, from that perspective, these are some of our resources that we, through our research, we recognize from an evidence-based standpoint that they tend to provide good services. And we just wanted to provide that as a resource for you so that you can have that for further use, whether it's for you or your family members or loved ones in your community.
And these are national resources, right? And so regardless of where you are, I know we have people from all across the country and all across the world probably on this platform. But this is a good starting point. This is a place that some links that people can go to get information and get referrals to more specific kind of localized resources should you need it. I'm gonna kind of bring us back in so we can stop this presentation, and if there's any questions or comments in the chat, we can field that.
Right. Well, let's go to a couple things. First and foremost, let me just comment to both of you, brothers Hinton and brothers Wright. Really well organized, timely, and an accurate discussion of issues that I think are remarkably germane, I think, to our community and others, in all honesty. But disproportionately, I think very often I'm sure there's some a famous person who made this comment first before we're going to say today, but the issue that when others get a cold, some groups get the pneumonia. And that's kind of the analogy for what happens to African American men who've been disproportionately disenfranchised and for a lot of reasons, systemic and otherwise, have a few resources to bounce back from stress and difficulty. But as I hear the conversation, and I think it was an excellent bidirectional conversation, there are really three questions that come to mind, or 3 points that I wanted to give you a chance to kind of address a bit more before we go to the chat. One, and you spoke about the issue of stigma in your formal comment, so that may be a bit abbreviated, but I particularly want, perhaps in this case, Brother Wright to talk about some things he addressed in regards to, why stigma is a bigger issue, a bigger problem for Africa in our community. I think that the data would support that. And you spoke about that in regards to social determinants of health, and I'd give you a leeway to go in that forward. I asked all three, so that's one issue. Next, for Dr. Hinton, this issue about African American men and what may be our trigger, what may be our outlet. And I'm often interested in whether the use of alcohol, the excessive and temperate use of alcohol, maybe even in a younger generation, marijuana, may disproportionately be a barometer of an attempt to address stressful difficulty in the lives of African American men when we couldn't have access, which you discussed earlier, when we were very often blocked because of stigma from going to, formal care for psychiatry and psychology and social work. I want to make sure I comment that I think I mentioned earlier, psychology, my introduction to Brother Wright, it's actually social work. I want to correct that. But also this idea that it's more culturally accepted. I'm always struck by this idea that, it's almost easier for some African young men to be a felon and get out of prison than have gone to see a mental health professional, because there's this issue that you point out of perhaps being viewed as being weak or not culturally accepted in our society. So don't mean to make these questions too long, but the issue of stigma, why us, the issue of Black men, what's unique about why we can't respond and what are some particular hurdles, and the issue about whether alcohol and marijuana are used disproportionately because persons can't find a way to go to professional care.
Yeah. Okay.
I'll start with you, Brother Wright.
Okay. Thank you, Brother Bailey. The concern around stigma and the African American experiences that we've talked about, our experiences here in North America for the last 500 plus years has been a challenging one. Yes, we have come a long way and we are doing great. We are examples of that, shining examples of that progress. And we are also the victims of, as I mentioned before, psychology of cruelty. One cannot overlook the work of Dr. Joy DeGruy, who talks about post-traumatic slave syndrome and the impact of that continuous notion that we were less than, that also we were pathologized actually as being, weak, right? And that we were mentally unfit. And as time went on, even though we know these are myths, they're not true, there's some aspects of it where our people embrace to their detriment, as I've said before, where we believe that if we show any sign of a mental health issue, then we're crazy. Those are the terms that we use, right? And therefore, we feel more comfortable speaking maybe to our pastors and faith healers around the issues of mental health. That goes back to my initial statement when we talked about health, that we must include the spiritual dimension or aspect of that. So the only way we are going to overcome that is to continue to have those discussions and those dialogues to break down the stigma associated with mental health, because we have developed new cultural beliefs and attitudes about this. All people get stigmatized. I don't think that the issue of mental health and stigma is inherently and solely an African American thing. But without a doubt, we have embraced this notion that any form of a mental health condition is a weakness for us as Black men. And again, in order to show our strength, we don't want to talk about that. We don't want to discuss it. We feel that if we do, it is a ding on our manhood. But I want to say today that a part of strength is being vulnerable, because in our points of vulnerability, that's where we can have dialogue with other individuals to talk about this. So as men, we have to have safe spaces where we can talk as men and not do the dozens on each other or think that he crazy or, he going through this, he weak. No, people have different issues. I think it was Noah Lyles who this year we looked at the Olympics, right? He admitted, look, I was suffering with bouts of depression. And because of that, I had to seek help. I was so proud of him as a Black man to say that, because therefore we see that when you own it and you take away the stigmatized around it, we are normalizing this. And that's what we want to get to, where we normalize mental health. Mental health is a part of our health. Black people, we are not the poster boys for resilience. And we too can have issues, and it's okay. We got to feel comfortable. I think my brother's keeper, I extended to that. We have to be our brother's keeper. We have to be our brother's keeper. Our brother's keeper means reaching out to a brother and seeing how that brother is doing. At my chapter, Omicron Phi Lambda, we have where on Fridays we reach out to brothers just to talk, just to see how they're doing, because we recognize the stress associated with these times. And that's not coming from a point of weakness. That's coming from a point of love and care.
I think, Brother Wright, you're spot on, and it really kind of sets me up nicely for this question about triggers, right? Mental illness is not equal to weakness, right? I see some of the questions. How do we teach our children? How do we talk to others? How do we deal with this mental health issue, our mental health crisis, if we're experiencing? We do it by not perpetuating weakness or associating weakness with having mental health treatment or having a mental health condition. Okay. We have to stop thinking self-stigma, or having that perception that if I go and get help for depression, if I go and get help for anxiety, if I go and get help because I'm paranoid or anxious, that somehow means I'm weak, right? Or somehow means that I can't tell anybody. I can only tell the pastor. Nothing wrong with telling the pastor, but there's nothing wrong with going to your physician, your psychologist, your psychiatrist, your social worker, your counselor, whomever, right? To talk about your mental health conditions. If you do that, particularly as men, particularly as Black men, if we do that, we show our kids, we show our children that it's okay to not be okay. It's okay to acknowledge that we're not okay and go and get some help for that. That's how we combat those triggers. That's how we figure out that we don't have to go smoke a joint, drink a six-pack, whatever the case may be, because we're so overwhelmed. We just want to numb ourselves. No, we want to experience it. We want to experience it so that it's not crippling to us. We want to experience it so that we can show our children, our family members, our brothers, our sisters, our moms, our dads, our uncles, that it's okay if we go out and seek some help. So certainly to be supportive of each other, our family members, our community, that's where we start. That's how you start to combat that stigma, Brother Bailey.
Alcohol.
Certainly, working in a paramilitary environment, working with law enforcement, this is something I tell people all the time. I got a rough day. I hear this all the time. I had a rough day. I'm going to stop on the way home. I'm going to grab a six-pack. I'm going to take it to the house, and kind of lay back and whatever. That's not okay. If you find that in order to relieve your stress or deal with your stress, it requires a six-pack of beer or, 5-6 shots of Hennessy then something else is going on. And we need to address whatever that something else is. That shouldn't be your go-to coping skill or strategy, right? We want you to be healthy. We want you to be able to come home, sit down, have a conversation with your significant other, have good interactions with your kids, with your family, not just numb yourself and then, by the way, numb yourself and then be numb from them. Okay. Numb yourself and then be numb from them. We don't want that. We want you to have healthy habits, healthy coping skills. And sometimes just having, as Brother Wright said, a positive network of folks that you can go to and say, hey, I had a rough day. Hey, I need to bounce this off of you. That's where you can start. It doesn't always have to be with a psychologist, psychiatrist, what have you. Just that positive group to go.
Yeah.
Yeah.
And I'm
Go ahead.
sorry, but the other piece, I think it's from a community level, as we talked about before, it begins with you, the individual, your family, and the block. It's also, I think we as practitioners, right, we're brothers in terms of the community piece and helping to educate our community around some of the genetic or biological pieces with that. So we know, Dr. Bailey, that if you're depressed and you drink alcohol, you become more depressed because it is a depressant. But we have to help our people understand that in lay terms, so we can't put it where they're not going to get it or they just feel like we're coming to them and talking down to them, but just really in a way to help them to understand that aspect of it as well.
And I see someone said, how do we, since I'm from a generation of boomers, how do we were built not to show, that weakness, those mental health issues. How do we get by that? We get by that by starting with us and saying, no, that's not the case. Just because my dad did it, my grandfather did it, my great-grandfather did it, doesn't mean I have to carry that forward. At some point, I can be that example. I can be the one that says, no, I'm not okay, and I'm going to get okay. I'm going to get okay by going and, seeking out therapy. I'm going to get okay by going and having a discussion with positive folks that help me figure this out. That's how we start. It's not, doesn't have to be, 50 brothers get together and decide, well, we're gonna march and protest. It can just start with me. Just start with the one individual, and I guarantee you, others in your circle, in your family circle, in your community circle, they will see it and they will go, oh, it's okay. Well, funny thing, I got that too. Let me figure out how to get better at that. That's how we start.
Yeah, I'd add that one of the points that I love to make is been a psychiatrist now for 30 years, and in my experience, these axioms that African American men don't go to psychiatrists are universally wrong or incorrect. I've never been able to go to a place where persons don't come to me and want to talk and engage with me as a mental health professional. Right. And one of the primary places is in fraternity meeting. I'm new to New Orleans, but I've been Alpha Phi Alpha Lambda in Houston for the better part of a decade. And, like many places, many times we have the brotherhood after the meeting, and there's a little drink there. And whether it takes a little drink for a person to get comfortable and get started or not, there are issues that people have to kind of get to. Because I like to say, Black men are people too, with issues and concerns and challenges like all other human beings tend to have. So this issue of stigma, that's why I saw you hit on your formal slides, and I appreciate that for both of you brothers. But I want to ask the question again, because I think that of all the things we can do, we can't do that much more. We can do a lot of value in these talks, but there's not many we can do more than combating stigma. Because stigma against having a brain illness makes many people not go for care that could have helped them. And that can lead to all forms of illness or morbidity, including and up to death or mortality. So now in my webinars, like to tie to this issue of vaccine hesitancy. I know we're on a mental health talk tonight, Brother Sterling, but I think you bring this into the equation, because I think that the misinformation, the fear, the concept that somehow our community is different or going to be handled differently or in a altered fashion, at the end of the day, if it leads to less healthcare, less accurate information, and less good overall medical decision-making and medical choice that leads to bad outcomes, then that's objectionable to me. And for healthcare professionals, I think, like all of us. So we've got to constantly, as you guys have done, I think, very well tonight, combat stigma. And one way is to say, if you're a brother and you go to a meeting, and you can't wait for the meeting to be over to pull brothers Hinton or brother, right to the side and discuss something in private, that's psychiatry to me. It may not be formal. You have an apartment. You don't have to come and pay for parking in my office. That's exactly what the other people get when they come into the office for psychiatric assessment. So the idea that you don't go home and talk to family about it, I think as Brother Hinton said, I think very articulately earlier, or this idea that, you have to always say, I'm good, is also a misconstruct. I had a brother on the phone with me the other day. I was in North Carolina for a while, and his son is a brother. He went to call, and we did a Zoom on a Saturday, and a lot of issues going on. And I appreciated him because he, the brother my age, was saying he didn't want his son to come up the same way many of us came up, being afraid to talk about these non-physical but psychological problems that every human being can have. Very proud of that, brother. And I think that with the issue that you guys are talking about tonight strikes, I think, at the heart of the message we have to get across to our brotherhood.
Yeah, I think, it goes back to the first slide in our opening words. It's health. It's overall health. Mental illness, mental health is a part of our health conditions, right? When you all join us and we're talking about HIV or AIDS or traumatic brain injuries or whatever, know that mental health is a part of that conversation. Part of that conversation.
Yeah.
So for everybody, if there's only one point that you take away from here, take away that mental health is equivalent to health. Okay. And if we are wanting to be healthy, then we have to take care of our mental health. We have to take care our cognitions, our thoughts, what's going on inside of us. Because if we can do that, then we can deal with so many other things much more efficiently and effectively.
Yeah. Brother Hinton, Brother Bailey, the other part I think that is a part of this, social work, we say we meet the client where they are. We got to meet people where they are. So sometimes when people come with those faulty assumptions, we recognize we don't invalidate where they stand, right? So we recognize where they are and we meet them where they are, and then we work with them to get them where they need to be. You see? So because we have to recognize people's health belief practices, and we've seen it even with this vaccination thing. Even though we are most impacted, numbers still show a lot of us, we are taking the vaccines, but there are pockets of people who are refusing to, right? And we see, issues, people talking about what happened with Tuskegee and Henrietta, things that have happened a long time ago, but they still resonate with us. And for those of us who might be have certain levels of education, we say, well, why, we're past that. Why can't they see that? Well, those things are real for those people. So we have to meet people where they are. I think that's the Bob Marley effect, right? Mm-hmm. People's perception is their reality. So when we recognize that, then we can meet them where they are on the ground level and have their conversation and take them to where they need to be so that they can begin to remove the stigma.
And we don't beat each other up, right? Yeah. Because we have some hesitancy, because we have some fear. We don't beat each other up, right? You want to combat that, be that example, be that person who can go up to that individual, that brother, that sister, that whomever, and say, I get it, but did you know this, right? I get your concerns, but did you know that I do, right? If we do that, we show an example, right? We make it real, we make it tangible so that people can't say, oh, it's just those people over there. It's just that guy over there. They're not like me. No, I'm here with you and I'm telling you, this is okay. If you'll just give it a shot, it's a great thing. It's a great thing. I tell my patients all the time, the best thing about therapy is you get to go in and for a period of time throughout in your day, you get to talk about you. You don't have to worry about if the other person had a good day, a bad day, if they're thinking about their grocery list, if they're thinking about whatever. It's just about you. And that is a rewarding process.
I think the pro-education message is an essential one in the era that we're in. I want to kind of put on the table this issue of how people get information. I think that we all have kind of touched on this issue of misinformation, whether you talk about social media, whether young people, I've got 3 young, they're not teens anymore, they're young adult children myself now, how much are they getting from their peers than they're getting from me or their parents, although their peers are 30 years younger than me and all my colleagues, if you will. Whether that's an issue of wisdom or trust, this aspect of being able to give misinformation to a group or community or society is powerful. And when people talk about misinformation, they're considering it being done intentionally. And how that affects our community, I think, is strident. I mentioned that piece. Brother Wright, you mentioned misinformation, but there are other opportunities to misinform our group. So I want you guys to talk a little bit about how people get the information, what they're likely to trust. I just comment. I mean, I'm on this show every week. I'm listening. We're not on. I look at the notes in the chat now, and brothers, some of your line brothers are responding. So because they know you, they trust you or us, and they believe in us. And that's how it used to be in our society for Black professionals in our stead. The fear can become it's hard to communicate with our whole society if folks are only going to listen to you if they know you directly, Melvin Hinton or Darren Wright, or they listen to the misinformation in social media that takes on a more prominent role. I'm interested in hearing what you guys' thoughts about that. It could be a big issue for us as academicians going forward.
And you kind of, Brother Wright, I'll jump in first and then toss it over to you. Brother Bailey, you're really kind of connecting your previous question really to this one about this information or misinformation that people get. I have a 10-year-old son, and I'm sure, like a lot of you, you'll relate that who have young kids. You'll relate that he's on YouTube, he's on video games, and he's chatting with everyone. But I make it a point to remind him that's fantasy land over there, right? This is reality. That's fantasy land over there. But I can only do that if I have the ability to communicate with him, if I have the ability to be present, if I have the ability to kind of sit down and have a relationship with him and be able to say, hey, what's going on? What are you hearing? What are people saying? So that I can give you correct information. I can't do that if I'm numb. Can't do that if I'm so stressed, if I'm so, despondent that I can't attend to what you're doing. Then you're at the mercy of whatever information comes. So how do we combat that misinformation? We have to be present. We have to care enough to put out correct information. If I put out correct information, that means that I've researched it. That means I have some knowledge of it. And that means I have some experience that I can then share with others that are in my circle. And in this case, I'm talking about my son. But we certainly share that in our chapter meeting, Kappa Chi Lambda and Lake County, Illinois. We talk about that stuff all the time. Well, here's what I heard. No, that's not the case. Here's what the truth is. That's how we do this. That's how we get right information, correct information, positive information out, and that's how we combat whatever's happening on YouTube and Facebook and whatnot. Darren?
No, Brother Hinton, I agree with you. I'd like to add, I recall when I was at Morehouse School of Medicine, we had a professor, Dr. Kofi Kunfwadi. He taught in the public health department, and one of the things he talked about was this notion of cultural humility. And I think it's important that we recognize, as we said before, even among us as African Americans, that there are dimensions in terms of socioeconomic status and how we were raised and all of that comes into play. So we don't all think alike. We're all not a monolithic group. And as such, I think we have to be aware of our own individualized worldview and our collective worldview, our perceptions. Second, we have to have a point of respect. So when we're understanding how we engage others, because through that respect, we begin to build trust and transparency, and people begin to feel comfortable with you. Secondly, we have to show some level of sensitivity again. So not shaming people, not making people think certain ways, or even in what we say or our body language or our paralanguage, because sometimes we may not say something, but our body language can also say things that we're not saying verbally. So I think those are some of the areas as well that when people see that you are being genuine and authentic, then they're better feel more comfortable to open up to you. Hey, brother, I want to talk to you about something. Man, this is what was going on. This is what happened. What are your thoughts? Then I can say, well, brother, man, I'm sorry to hear that. And then we can direct individuals to where they need to get the right help. But if the person approach you and you may not, you're listening, but your body language says something, that person's not going to open up to you. They're not going to be authentic because they recognize that you're not being truthful and transparent, and they won't trust you with what they want to share with you.
I see, Brother Wright, someone in the chat, I think this is Brother Doss, Richard Doss, says, as a soldier or a police officer, is it safe to talk about my mental health issues, or does it put my job at risk? I think the underscore here is safe and safety, right? Mm-hmm. We talked about, in the beginning of the presentation, we talked about access to care. Do you know how to navigate your health care? Do you know how to navigate going to a particular caregiver, a physician, psychiatrist, psychologist, social worker, so on and so forth? If you do, then it is safe for you to do that, right? My police officers, my correctional officers, I tell them all the time, I want them to come to work with a clean uniform, and I want them to leave work with that same clean uniform, right? You can't do that, in my opinion, effectively if you're not mentally healthy as well. So in order to do your job as a soldier in our, protecting our country, as a police officer who, has to deal with unimaginable situations, you got to make sure your mental health is sound, that your mental health is in a positive state, because otherwise, doing the work that you all do in particular, you're automatically at risk. You're automatically at risk. So you got to find that safe outlet, that safe therapist, that safe physician, that safe counselor to go and talk to. That is absolutely essential and important.
And I think that our systems and structures have to embrace that as well. There has to be an embracing of policies, practices that support mental health and doesn't stigmatize it. So what, like that brother just shared, as a police officer, we can say this, but if there are not policies and practices in place that support that, they're not going to come forward. And we continue to see that. That's where I think a lot of the challenges are.
Speaks to culture. Like I was earlier, you guys know New Orleans now, but I was here 25 years ago, my first job. And one of the roles that I had on LSU faculty then was we had the New Orleans police contract. So people would come to us for an assessment, a psychiatric, before they could even qualify to go to the academy to start the process. And I've been saying this for 25 years, and I'll say it again tonight. I was struck then and remain somewhat, still a bit surprised today at the overt level of pathology, to use, I think, our fancy term, that existed in individuals who were considering going into a into a police department. That was really much more about culture, I think, than about just individual. So certain settings, certain cultural environments attract individuals who may want to be more hostile or antagonistic or aggressive, which may be the point that Brother Chadas pointed out, or the flip side. So the reality is that people should be comfortable thinking about that and addressing it. If you're inside one of those settings, trying to find ways to challenge it. If you're in a bad job or in a setting where there's domestic violence, or if you're in an environmental setting where persons are being unfair and discriminatory toward you and there's bias, all issues that I think kind of come into play. And the issue of race very often is a signature one in this overall discussion. It's not always an issue. It's not even always the main issue, but it certainly can be. And when it is, the person who feels vulnerable, that they're being mistreated because of such, you shouldn't be afraid to address and talk to and think through all of the parameters that might lead to, whether it's their race or their gender or their ethnicity or whatever the case may be, their religion, being the reason why that discriminatory bias is actually adversely impacting them. These are all aspects, I think, of promoting your own quality mental health. Decreasing the risk, I think, that the stress will grow and build, and at some point somebody will meet criteria of having clinical depression and needing biologicals, medications, as Dr. Hinton mentioned earlier, or you can't really, I think, tie many of the structural settings together that are necessary for, I think, quality psychotherapy to work and be helpful. I kind of want to circle this discussion into a term I want to use earlier, and I'll use it now. So now one of the operational terms in the psychiatric literature is what we really need is total health. This idea that, of course, there has to be primary care and basic medical health. And of course, there also needs to be quality mental health, as I think has been stated very well tonight. But also there should be a public health dimension to the things that we actually are considering. Very often there are global issues. The discussion of social determinants of health is one of them that also impact these settings or these roles, and can also, I think, decrease the likelihood of young African-American men having struggles in their day-to-day lives. All issues that I think should be put on the table, because any one of them can lead to failure in someone who's trying to find balance and homeostasis, so to speak, psychologically. I also would argue that much of the conversations you guys have made tonight can extrapolate across formal settings. So for me, I like to always share with individuals that you can go to your parent and your sibling and your frat brother and your cousin and your college roommate and your neighbor and your coworker and talk about these things. People have to have an outlet. And very often it does come down to the term I think that our Brother Hinton mentioned. There has to be trust with the entity and the group that you're speaking to. If you feel like it's confidential, it won't come back out, but also it kind of helps you kind of move forward. So the question I share with both of you is, how do you help individuals as they're trying to build that trust? Because they have to trust you to come and talk to you. I think that point was made earlier, but they may want to build trust in someone else and triangulate the relationship to help them, I think, find ways to move forward when these challenges exist.
Two things I'll say, and we maybe we can keep a kind of global view here, so Brother Wright can jump in at any point in time. I would say two things. First, people will trust as they look at you, right? How do you carry yourself? How are you presenting? Not just when we're talking about whatever the problem is or in our one-to-one conversation, but they'll look at you or look and observe you as you're interacting with others, right? That's one thing. Another thing I will say is, and this I tell patients this all the time: if you have established some rapport, some trust with me as a psychologist, as your therapist, and you said to yourself, well, this he ain't half bad, right? He ain't half bad. And I think I'm comfortable and this is working. Then I will remind them that you can then trust someone else, right? Because there's nothing magical about me, right? If you can find that trust with me, with your therapist, with your family physician, with your general practitioner, with whomever, then it is possible to find it somewhere else, right? You now have the courage and you now have the history, the skills to establish it with someone else. So just doing those two things and kind of keeping those two things in mind kind of helps move that conversation forward.
I think Dr. Wright will give you the last word. Then I think we're going to turn it over to Brother Sterling.
Yeah, Brother Bailey, I concur with Brother Hinton. Again, I go back to the fundamentals. A part of trust is respect. And people will look at you. They will look at how you carry yourself, how you interact with others. And that makes a determination whether or not they feel they can trust you. So that's that human dimension as well. Okay. So it's not about our titles. There's no, and all of that. It is how much they feel they can trust you. And when they share information with you, that you will not, it won't be out there with other people, you see? And that's the starting point for any relationship. It is based on respect. From respect comes trust. From trust, then we can start talking about confidentiality and moving people to the right individuals. And it might just be their family members. It might just mean just having that discourse or that discussion, and then from there taking it to the next level. But I think that's where it has to begin, whatever level, that we begin to see the humanity in people. We begin to recognize, again, we are not superhumans. We were treated as property. We have, again, that psychological baggage that sometimes we do not like to discuss. We have to understand we are human. We are no different. We are not the poster boards for resilience. And when we can stand on that firm ground, then we can deal with people from a point of respect, and from that will come trust.
The issue about trust, I think, also leads into a further discussion about how we actually build and foster relationships. I'm interested in your thoughts for both of you on this concept, because for so many of, I think, of our young men, maybe not in the fraternity, because most fraternity men are, well, all fraternity men are college educated and college degreed, and so many have had many of the other successes, I think, that that life in our country can allow.
Right.
I think very often that may not be the case for some. Certainly for many in our families, mine as well. We may have relatives, young men that have tripped up along the way, and that can actually challenge familial or family-based relationships, and that's kind of hard to maintain. I think that some of the challenges in my work has been not just when somebody's an individual, and I can kind of work with them on that psychological piece. I love the concept of biopsychosocial work that we do, but the psychosocial piece, when there's a group that's involved, when there's family dynamics, often I think is problematic. And I think that young men in our fraternity need to hear what your thoughts are regarding how do they engage to keep family dynamics together when they are challenged or when there are problems, when somebody's gone to jail or prison. Dr. Hinton, I think, has really failed in the individual aspects of relationship in life, marriage or work or education or housing or the like. These are huge issues, I think, in our community now, and I think they also impact our fraternity. I'm interested in hearing your thoughts about them. These are challenges for me in my daily practice, and they're not easily answered.
Yeah, I agree, and I know we're short on time. I will kind of come back to this and say this is why we started off saying global presentation and probably step one in a series, because things that folks are talking about in the chat, this question, Dr. Bailey, that you just advanced, that's a whole presentation in and of itself, right? Going to prison or being incarcerated, unfortunately, in this country, is pretty common, particularly for people who look like us. And there's some thoughts I have on how to combat that. There's some realities that people need to be aware of. One of the most important is something that I remind people all the time is the majority of people in prison are coming home. Majority of people in prison are coming home. And so it's certainly my responsibility as a psychologist, first and foremost, as a Black man, first and foremost, to do everything that I can to set them up for success coming home. Because I want you to come home and stay home. I want you to come home, stay home, and be healthy in that process. So a lot to unpack there, Brother Dr. Bailey, but I think Brother Wright and I are in full agreement that will be series 2 or step 2 in our presentation as we move forward.
Well, if I understand the metrics right, I think I have 8 minutes, so I don't want to cut you guys short. If I do have that, I have an idea. One thing I like, both of you sound, I mean, the richness of the conversation is striking to me. And again, I commend you both. And I want to throw this football, if you will, the football season to you Chicago Bears fans. Throw this ball your way. I want to give both of you a chance to kind of answer this. Tell our audience a little bit, I'll give you a minute each, about a successful case you've had addressing a Black male and his problems in individual work with you. And I like to ask this question, it goes without saying, because for those who may question whether others go to therapy, we can say all day long that they do, or the question whether or not therapy will help them, or our kind of work we engage in can be of unique benefit to them, I think is also often an invisible barrier that African-American male mental health professionals like the three of us have, that I think often is the invisible albatross in the middle of the room as you're trying to get somebody to come in for therapy, take access, and then trying to get them to come back for a second visit, if you will, having to get them to fight that issue. In fact, I'll share that one data I'm always interested in is data point that says that our profession is the one people are most likely to go to the doctor, get a prescription, and never get it filled the first time. A huge issue I've always thought with stigma and fear and the uncomfortableness of having to see a mental health professional. But that being said, one successful case, non-confidential, of course, but just to, I think, share with our audience a bit about how you've managed some of these concerns that I think both of you have discussed, I think, very articulately throughout tonight's discussion. We'll end with this.
What do you say, Darren? I'll go first, and then you can wrap us up. Lots of examples come to mind, which is something good, I guess I can say. I will say this. I've had a couple of patients who came to me and said, Doc, I want to thank you. I want to thank you for all that we've worked through, all that we've gone through. I want you to know that because I saw you, black male, born and raised in Detroit, Michigan, inner city, because I saw you figure out how to make it through all the stuff that you went through, school, workplace, to get to the level that you are, to then help me. I now know that I have a responsibility to show that example to my kid, to my, brother, sister, what have you, and I can be better for them. That, for me, was really gratifying, really powerful to have patients volunteer that and say, I'm better because I saw you. And because I saw you, I want to be better so that the people who look at me could do better.
Well said. Brother Wright?
You might be on mute, Brother Wright.
Sorry, you threw us for a loop. That was good. I recall, I grew up in Brooklyn, New York, and I initially began, as points out in my bio, working really in the corporate side before entering into social work. I always had a passion for people, but I worked on Wall Street for many years and then transitioned into human services during the Bill Clinton era when there was the welfare to work programs. And I cut my teeth in human services, working with individuals who were dually diagnosed. And I recall a young man showing up my first day for a group, disheveled. And I said, this guy's not ready for work. And my body language said to this young man that I didn't appreciate the way he showed up. No tie on, he was dirty. But I had to go back and deal with some self-reflection and look at this brother from a strength perspective and say, the mere fact that this young man was here in the office means he's ready. So I had to meet him where he was to deal with the issues around what it means to get a job and keep a job. And secondly, to work with him around his mental health issues because he was young. He did not want to take his medication because at that time they were using stuff as Cogentin and Haldol and the impact that had on him in terms of impotency. And we had to work with that in terms of, let's talk to your psychiatrist. Let's look at what other medications might be more appropriate for you. And also just educating him as we work together to look at you taking medication will help you in your recovery. And I had to embrace mental health as a recovery process, that you may go far and then something can happen and you have a psychiatric episode and we need to restart, but that's okay. You went as far as you could in that journey, and then we had to retool again, look at where those shortcomings were and how do we now move forward in a different way with the new knowledge set so that you can be successful. That young man went on to get a job and work at LaGuardia Airport. He started off as a baggage handler. I was a job coach. I provided the supports for him as he was making that transition. He was able to go to college. Didn't mean that he didn't have psychiatric incidents, but he understood that that was a mental health condition. And like any other condition with the appropriate supports and medication, it could be managed. As we said in the beginning, that health, overall health, it does not mean the absence or disease or infirmity. However, how we manage that and still move forward with our lives is what we want to do and help our clients with. So that's my success story of how I've worked with individuals who have been dually diagnosed, African Americans, Latinos, and others, and just to help them. I approached them from a standpoint of humanity, had to self-reflect and recognize it wasn't about me. And I had to see the strength in that person to meet them where they were.
I'll share mine, and I'll give both of you guys 30 seconds to close, and then we'll be done right at 7:30 Central. Mine very similar to yours, Brother Wright. I was medical director of a mental health center in inner city Nashville when I was in Meharry, And a lot of stories, as Brother Hinton says, but the one that I'm always struck by, I also do forensic work. We had a 36-bed residential treatment facility. So people come, a judge would have them legally have to come and live there and stay. And if you went out, you essentially break probation and they may capture you and kind of go back to jail and all of that. So persons would come, and often they would always have chemical dependency problems. We had these SAMHSA substance abuse grants. And we had one young guy who had, whether he was a gangbanger or not, I'm not sure what term to use, but he'd definitely been around entities where there was shooting and that type of business, and he had been shot. And I remember in talking to him about him at some point saying, Doc, if I had known it was going to really hurt this much, I guess physical pain to be shot, I wouldn't have really, been in that game and kind of lived that life. Yeah. And I was always just so struck by that. And I've been thinking about this for 10 years of my career now. One, a lot of our young guys just really don't have a clue of what life is really like, what the risks are really like. I think we think of death and dying as professionals sometimes different than they do. Yeah. Maybe why it seems to us like many young men take so many risks, and risks that may put them at risk of harm or danger. In addition, I think the reality was a lot of the antecedents of the violent risk can be the use of alcohol or marijuana or whatever the case may be, because folks very often have an empty spot. If you don't have a family that gives you a chance to get a quality, education and a job and that type of business, it's easier for any of us, myself included, to kind of go the wrong way, so to speak. So we got to find ways to help understand and to kind of patch that piece back together when young guys come in who are really not doing well. I love your point, Brother Wright. I like you at times think, why did somebody come in this way? You're not dressed appropriately. You're not playing by the rules that American society has said you have to play by. You come and see me for an appointment. And I think like you, I have to kind of check myself that, that young man I'm seeing may be coming in with a whole lot more deficits and albatrosses, I think, around his neck holding him down than I could ever really imagine. This story, as you might imagine, is positively. This guy got it together, got off the alcohol, or drugs, whatever the case it was, and kind of went a little straight and narrow and got a job in that type of business. And when you get a little feedback, similar to your story, it does warm my heart as professionals that this talking work that we do, people often say, you're going to go and talk to somebody. What we do, this talking work we do does matter. And I think it matters to people's lives. And I think we have to make sure we can promote it as best we can. Yes. Let me give both of you guys 30 seconds to end, and we'll be done. Brother Hinton, Brother Wright, who'd like to go first?
I would just like to say again to our Surgeon General, Alpha Surgeon Brother Sterling, Brother Bailey, to my co-presenter, Brother Hinton, to all of the brothers of Alpha Phi Alpha Fraternity Incorporated, to my beloved chapter Omicron Phi Lambda, and our listening audience. Thank you. It's an honor and a privilege to have had this opportunity to have this discussion with you. Not a lecture, not a presentation, but hopefully that we all came aware through this shared meaning from a global perspective of the importance of mental health, and that it is a part of our overall health and well-being. Thank you again for the opportunity. Greatly appreciated. Thank you.
Agreed. Thank you all for this opportunity to, as Brother Dr. Wright just said, have a discussion. And I certainly hope not the last discussion, but just the first in a series. This discussion or this format that our Surgeon General has put together, that our General President has put together, is so important. So important that we face inward, not only towards our fraternity, towards our brothers, but also towards our community to share our resources. I'm very, very moved and very supportive of this effort, and I'm looking forward to continuing it. So, thank you all. Appreciate your time.
As well, I think that it goes repeating that General President Alonzo has really outdone himself with a tremendous idea in putting this program together, and he deserves tremendous credit for it. And I give tremendous credit to my long-term friend, Surgeon General Jeffrey Sterling. I think that his organization has been impeccable. Just kind of comment as we bring this to a close that next week, the Surgeon General Initiative will have a topic on dental hygiene. It'll be next Thursday, 10/21/21 at 7 p.m. Eastern. We ask all of you to tune in I think it's been a good series, and let's kind of keep it going. And I'll end by just thanking my co-panelists. You guys have been just outstanding today, Brothers Wright and Hinton. Thank you very much. Have a good evening.
You too.
Thank you.
Thank you. Have a good night.